Brett said we're good to go now.
Very good, thank you very much indeed. Good afternoon, Mr. Dunlop.
I'm just checking this mic's on. Yes, it is.
Can you hear me, Mr. Dunlop?
Yes, I can, thank you.
Good afternoon.
Good afternoon. This afternoon we have two witnesses speaking to one statement. We have a Dr. Williams and a Dr. Lunan. Lunan's joining us remotely. My lord, if it helps, the reference for the statement is SCI WT 0428, then 5 zeros and a 1.
Good.
Thank you.
Now, good afternoon, Dr. Lunan and Dr. Williams.
Good afternoon.
Good, excellent. I can see you both. Yeah, great. If you're ready, Mr. Dunlop, just start, please.
Thank you. I wonder if you could provide the inquiry with both your full names, please.
My name is Dr. Carey Lunan.
And I'm Dr. Christopher Morgan Williams.
Yeah. And it might be helpful to explain, for the benefit of the inquiry, that you've both held the same position but during the pandemic. And I understand we see in the statement in the table that's in paragraph 3 that Dr. Lunan, you held the post of chair during the period from, well, the whole of 2020, and thereafter it was taken over by Dr. Williams for the remainder of the period which we're interested in, which is 2021 and 2022. Is that correct?
That's correct.
Yes. And to avoid, and I think we've spoken about, to avoid people speaking over each other, what I'll do is, as a sort of default, if you like, given that you were involved in the earlier period, Dr. Lunan, I'll maybe ask you to answer the questions, and if Dr. Williams has anything which he thinks he can usefully add, I'll turn to Dr. Williams. Obviously, if the question's particularly geared towards 2021 or 2022, then I'll direct it in the first instance to Dr. Williams. Now, in the statement, it's explained that the Royal College represents 5,000 general practitioners in Scotland. Are all the general practitioners in Scotland a member of the Royal College?
No, they are not. It's a reasonable majority in Scotland, but it's not all GPs in Scotland that are members of the college.
Can you give us an approximate number of GPs that practice in Scotland?
There are just over 900 practices in Scotland. I think the percentage, certainly when I was chair, was between 60 and 70% of GPs were members, but I'm not sure what the current percentage is. It changes a bit from year to year.
And I maybe misheard you there. Did you say 9,000?
No, 900 practices.
Oh, 900 practices, sorry.
Yeah.
And how many GP, do you know how many GPs there are, the full-time equivalent GP posts?
I don't know that, no, I'm sorry.
I'll direct this to you, Dr. Lunan. At paragraphs 5 to 6 of the statement, you tell us that GP practices remained open throughout the pandemic and that face-to-face appointments were available where it was both safe and appropriate. Could you tell us what firstly is meant by safe and what's meant secondly by appropriate?
So this was a very key part of the way that we had to change the way that we worked during the pandemic, subject to the advice that we were getting from Health Protection Scotland around maintaining safe clinical conditions to see patients and safe working conditions for staff. So at the start of the pandemic, the advice was that we spoke to everybody first on the telephone to try and assess what their needs were. If it was straightforward and safe to assess it purely over the telephone and deal with the medical needs without having to bring somebody into the practice or visit them at home, then we would do that to minimise footfall into the practice. And that was just to reduce the risk of transmission of COVID-19, particularly in the early stages when the virus was more virulent, it was stronger, there wasn't vaccination. We were trying to do what we could to minimise risk across the whole system. But when we did speak to people on the phone and we realised that we needed extra information that a face-to-face appointment would bring, like for example examining somebody, or if they were very worried about something and needed to see us face-to-face, then we would accommodate that and either see someone in the practice or see them at home in their own homes. it wasn't straightforward to do that. If we suspected that if somebody had symptoms of COVID, for example, in the very early stages, we developed places in the practice that we could see them often separated out from other patients in the waiting room in different areas of the practice, so people might be asked to wait at different point and come into something called a red room or a hot room, where they could be seen separately and the room could be cleaned more thoroughly in between patients, and those patients would generally be seen by a doctor who themselves had lower risk of COVID if they were to contract it. But in general, what we did was we always offered face-to-face appointments, although the proportion of face-to-face appointments as a whole was lower than it would have been pre-pandemic, and that was purely for safety reasons. The appropriateness part of it, again, was related to whether or not bringing somebody into the practice or seeing them at home would add useful additional information that we couldn't reasonably collect by speaking to someone on the telephone. So, for example, if somebody was phoning up with significant abdominal pain, which is quite difficult to assess without examining somebody, then we would be more likely to bring them into the practice to see them and examine them, or visit them at home if they weren't able to come in, than say if someone phoned requesting a sick line for work, which is something that is more straightforward and could be managed over the phone. So it varied from consultation to consultation, and we had to use our judgment and knowledge of what the infection control guidelines were at the time to make a decision about whether we could reasonably deal with it over the phone or bring somebody in.
Okay, thank you. And just, you mentioned Public Health Scotland there. In terms of safe and appropriate, were they definitions contained within any guidance that was issued to medical staff?
I think so, but I would have to go back and read the original guidance. That feels like very familiar wording from the start, that was how clinicians and practices were being asked to consider how they make that difficult risk-benefit decision about bringing somebody in or seeing them at home or being able to manage someone over the telephone. I think we all realised as clinicians that doing things over the telephone is far from ideal. It's not the way in many circumstances that we would prefer to be doing things. It can work really well for straightforward, more transactional healthcare issues, but it is a way of consulting that is more complex, because you have to be very careful about making sure that you've fully understood what someone is telling you, that they've fully understood what you're advising on, that you've got a plan in place if someone is to become more sick so that they know when to contact you back, and that you're confident that without seeing them you're able to reasonably manage the risk associated with that. So it's not a faster or easier way to consult. It was purely being done on the basis of what we needed to do at the time to try and minimise infection risk.
Just one last question on this point, but if it's a two-stage test, the safe and appropriate, or appears to be a two-stage test, if one of those tests wasn't satisfied or both weren't satisfied and it wasn't going to be possible to go, what would you do in circumstances where that individual wasn't able to have an appointment remotely? So I take, for example, an individual who doesn't have access to IT or maybe has learning difficulties or something, but it can't be done remotely, yet the test can't be satisfied. What would have been done in those circumstances in your experience?
So in those circumstances, we would want to see someone. So if we were not convinced that either the safety or the appropriateness argument could be met, then we would have a much lower threshold of either, if someone was able to come into the surgery, inviting them to come into the surgery and obviously asking them to wear a mask and to follow the social distancing guidelines in the waiting room, and that we would see them wearing PPE, so we would explain all that to them on the phone. And if they weren't able to come into the practice because they were too unwell or for any other reason, then we could arrange to see them in their own home, which wasn't without risk as well. So we were very aware of the fact that remote consulting was more problematic for a number of different groups of patients, such as the ones that you have mentioned, maybe people with learning disability, cognitive impairment, lack of access to equipment, lack of access to a private space to have a conversation, and that was very much in the forefront of our minds and fed into the decision about whether or not someone could be safely and appropriately managed over the telephone.
and as you identify within the statement, there's this public perception that the GP surgeries weren't open for business, or not certainly to the same extent following the pandemic. As we move into 2021 and 2022, we've heard for Dr. Lunan. Is there anything? Did things get better in terms of face-to-face consultations? Can you speak to 2021 and 2022?
So the changes, the organisational changes that we went through in terms of how each practice was operating were seismic. We had a large number of systems in the background pre-COVID that staff were familiar with, comfortable with, that helped support patient safety, that worked together, and we needed to these systems were disrupted by needing to bring in remote consulting and remote consulting for a large number of things that we historically would have taken in our stride in a face-to-face manner. And so I suppose as we reached the period that you're talking about, we had a lot more time to test the video consulting, for example. We were able to check whether the purported benefits were there, whether these were technologies that were embraced by our patients, or which parts of our patient population liked or were comfortable with some of these different technologies. And I suppose ultimately we found that using the phone was in many ways something that we could flex, that we could get the most out of in terms of rapid transferring of information or trying to understand what somebody needs at any one point in time. And I suppose to say general practice, doing things face-to-face, trying to understand what our patients' needs and wants are, trying to get a sense of which tests are appropriate, or which from a number of different routes might be best for someone, or helping them understand the different options open to people. So it was a difficult time to leave behind so many of our comfortable working practices, to try and to sense check which changes were working, which were not, and again, which practices we could go back to. In some ways, some of the things we did pre-pandemic, we found we wouldn't go back to. That times had moved on, that how people were using the health service has changed.
I'll come on to matters about people coming in during COVID, but one of the things that I know, and it's at the early stage, in paragraph 5 and 6 of your statement, you identify that a number of GP practices weren't suitable, essentially, for the pandemic world, if you like. And my interpretation of what the statement says is that seems to be largely to do with an issue of space. And I'm just wondering, with the benefit of hindsight, do you think there's other things that could have been done to deliver services face-to-face, where it's obviously the GPs are capable of doing it, but when the buildings, if it's the infrastructure, do you think with the benefit of hindsight and the lessons to be learned, which the inquiry will be looking at, there's something that could be done differently?
I might highlight, so in terms of vaccination, when vaccination was carried out by general practice staff, that there was a flexing, the use of church halls, of school buildings. Now, in some respects, some of that was very problematic about who was carrying out risk assessments, or whether permission was given, whether it coincided with term time, or whether there were other events booked. And I'd say there's a surprising amount of barriers for some of these buildings that were owned by local authorities and should have been converted to, for different purposes. One limitation we have in general practice is we do a lot that relies on electronic communication between a variety of systems. So there is an infrastructure in terms of the SWAN network across health and social care and other local authority premises. So it's conceivable that there were other buildings that could have been that could have been brought into use, but I'd say if there had been that foresight, or if there was an emergency plan switch that could have been flicked, but what we in practice encountered was that there was lots of different ways of working between local authority and NHS, for example, in terms of how a building might be deployed or used.
Okay. You mentioned obviously the planning of it. In terms of, and we'll hear perhaps this year, perhaps next year, but we'll hear about various exercises, pre-pandemic exercises that were carried out, such as Silver Swan. Is that something that's familiar to you? Do you know that?
So I'm familiar with exercise Silver Swan, but I suppose only because midway through 2020 that there was the sort of publication of papers from 2015 and 2016. I have done work with Basic Scotland, in terms of being an emergency responder. There are many GPs in rural areas that try and make themselves available to be part of an emergency response. I think even amongst this community, you would find a limited number that that were aware of planning round about pandemics.
I mean, my question is in relatively sharp focus, and I'll ask Dr. Lunan the same question, but I wonder whether you have a view on whether the pre-pandemic planning in respect of the delivery of GP services was adequate, and if it wasn't adequate, is there anything that could have been done differently?
So I can recall going to major incident planning meetings in Highland in 2015, and a lot of the sort of incidents that they were planning around weren't pandemic, weren't infectious disease related. They were related to power disruption, to vehicle crashes, to incidents that might appear across the patch. So yeah, I do wonder that exercise Silver Swan should have sent a message that should have been more widely received.
And if I put, sorry, Dr. Lunan, I hope you heard the question that I put to your colleague, Dr. Williams. If I was to ask you the same question, whether the pre-pandemic planning was adequate in terms of the delivery of GP services during the pandemic, I don't know whether you have a view.
So I guess my reflection would be that the vast majority of GPs working on the front line would not have any awareness of Silver Swan. I didn't, as a GP working on the front line. I think that there were GPs who had specific roles, such as Dr. Williams mentioned, being involved in pre-hospital care because he was a GP working in a remote and rural setting, or other GPs with specific roles within local board areas. But the vast majority of frontline GPs would not be aware, I think, of strategies like Silver Swan. So I think there probably is a case for more general awareness, certainly of maybe a key member within teams or practice managers, but also I think there are some other things that would be useful to learn about. So you mentioned space, thinking about looking to the future if we needed to have social distancing again, and that was the main rate limiting factor to being able to see people, then I think we would want to see faster mobilisation of use of other spaces. We probably didn't have the IT infrastructure that we ideally could have had as a modern NHS pre-pandemic, but that was rapidly accelerated in the first few months at enormous speed, and I think something that we should be really proud of. But so within a few months we all had cameras, microphones, were able to use Near Me consulting platform and Microsoft Teams, and that was unheard of before the pandemic. So there were some silver linings in a way, if there can be any, during something that was so difficult for so many people. And PPE, I guess, is the other thing. in terms of ensuring, do we know how we order it? Do we know what we need? Have we got adequate supplies to keep us going for the the initial period? I think all of these things would be very forefront in our minds if there were thoughts of planning for a future pandemic. If you don't mind just going back to your previous question just really briefly around space, I think that space is important to consider, as Dr. Williams has said, as is having the adequate IT, but there are other issues as well that make it less straightforward than that, such as the ability to clean spaces, such as the ability to have air circulating. But the main limiting factor to being able to see lots of people face-to-face in longer appointments with the need to clean in between and change PPE is workforce. So that would be a rate limiting factor no matter where the premises was. We could open up bigger buildings and have more space and bring more people in, but we still need to have the staff there to see them. So we may come on to workforce later. Thanks.
And can I ask, just dealing with that, if I call that infection control, in terms of, and this might be a better question to put to you, Dr. Lunan, given that you were dealing with, or you were more involved at the earlier stages of the pandemic, I mean, what impact did infection control have on the number of patients that GPs could see? I mean, maybe you can tell us relatively briefly in the time that we have, but was there a cleaning regime between every patient, every second patient, and what was the impact on the number of patient appointments in the day?
So in the briefest terms, there was a cleaning regime that had to happen between every patient because we didn't know who was asymptomatic and had COVID, so we had to clean down all surfaces between each patient coming into our consulting rooms, and we had to change PPE between patients as well. We also had to, many practices, if they had space to, would run this second room that I mentioned earlier on, a hot room or a red room, to see people who had symptoms of what we assumed might be COVID, so continuous cough or fever or loss of smell, and those rooms would be cleaned even more thoroughly and staffed by someone who was assessed to have lower risk and was more able to see those patients with less risk to themselves. So the impact was big, because normally we would see in a face-to-face appointment is still, sadly, 10 minutes. We would love it to be longer than that moving forward, but 10 minutes is the average length of time for a face-to-face appointment. But when you then factor in changing PPE, cleaning down the surfaces, and all the work that is going on before someone comes into a consultation with social distancing in the waiting room, standing 2 metres apart in a queue to log in at the front desk, handing out masks to people who don't have masks, everything was slower. And obviously people were also anxious or frightened and had lots of issues that they wanted to discuss when they did come in, so the appointments tended to be longer. So it did significantly impact on the amount of people that we were able to physically see during a normal working day.
And you may not be able to put a number on it, but if I asked you to put a number on it, did it halve the number of appointments? Did it reduce them by a certain, a third? Are you able to?
I would say we'd at least half them.
At least half. You mentioned PPE there, and I wonder if I can just maybe ask a couple of questions about PPE. Immediately before the pandemic, what were the kind of procurement arrangements for GP practices obtaining PPE? And by PPE, I have in mind masks, gloves, aprons, the kind of what I might call the conventional PPE that medical staff might wear. How would GP practices obtain that?
So they would normally be ordered through the board, the health board, and there's a national distribution centre, so it would be usually the practice manager of a practice that would be involved in ordering in stocks, and that's how it began, or that's how it was done at the beginning of the pandemic.
Thank you. And I think I'll maybe put that question to Dr. Williams as well. I wonder if he's got an insight into it.
So there's a system called PCOS, P-E-C-O-S, that can be used for ordering items of equipment. But although it brings some computerization to the process, it's not then linked into any stock control or inventory systems within the practice, so that there very much is a process, I suppose, of manual counting, or trying to know when a practice by practice, but each practice would have its own system of what it's keeping track of, or how much it thinks it's got of one item. So pre-pandemic, you're not using very much PPE unless somebody's coming in, sort of coughing and sneezing, and you want to avoid droplets, or you're doing some minor surgery, you want to avoid body fluids, and suddenly when you go into the pandemic, you've got dynamic risk assessments around everything that you're doing. And I suppose in telephone terms, you didn't need PPE to use the telephone, so you could keep up a pace. But there was different PPE that would appear in our surgery at different points. And some of it was sort of manufactured to different standards. I'm not clear how that related to the ordering. In most practices, you would find that the ordering is then given to someone who can do it consistently and who can go around and check what items are in the stock cupboard and within the rooms, and would top up. So often that might be a healthcare assistant, for example, or somebody whose governance is either through the practice manager or the nursing team.
Was there any guidance in relation to, I don't mean stockpiling as such, but having a minimum quantity of PPE? Was there any guidance either issued nationally or by the Royal College or any other body?
There was a checking process that occurred, I think, on a weekly basis, for boards to be reassured that practices had adequate PPE. And I think that then reached a yes/no, on a practice by practice basis. But I don't know what whether that was a value judgment or rather than numbers, because there was times when we were going through large amounts of PPE, especially when we were able to open things back up and go back to a bit more of a familiar turnover of people in the surgery for face-to-face, for a sequence of face-to-face appointments.
I mean, I should have asked that at the outset. During the pandemic, Dr. Williams, were you a practicing GP during the pandemic period?
Throughout the pandemic.
Yeah. And Dr. Lunan, the same? Yes.
Yeah. Yes.
You've told us about the systems. The pandemic occurred at the end of March. There's not much in the PPE shelves in the GP practices. What were GPs doing then to obtain PPE? Where was it? How would you go about obtaining it? So
GP practices have always been able to source bits of equipment, either healthcare equipment or computer equipment, or things that they thought were necessary that went above minimum standards. So even where a health board is responsible for providing items, and I suppose PPE was no exception. We would have patients come and drop off scrubs that they had made, that they had fashioned from curtains or bedspreads or all sorts of things. People were trying to do their bit to help. We had protective body suits, that painters and decorators might use that people had dropped in. It was, I suppose, less easy in terms of the face mask side of things. That we were given guidance, and I'd say that I think across general practice there were people that were wondering about whether FFP3 masks were available, whether there was a step up level of protection, especially for people that might be involved, as I say, as emergency responders, or who have a more of an extended role than what you might view as some of the more general practice.
Did either of you or any of your members that you're aware of run out of PPE that you're aware of?
We heard lots of expressions of anxiety and nervousness about PPE, and I think that stretched across people thinking that either they had. I've had experience of aprons that weren't that were repurposed bin bags, that weren't easy to put on and take off without without them having then shed any droplets or particles that might have got on them. Some of these things, some of these items were not the level that we'd hoped for. There were masks that had new expiry dates that went on them. I also remember that particularly vividly. It wasn't in my practice, but again, these were masks that are deemed to have a longer shelf life than initially thought.
Sorry. It seems to me that there's two issues arising out of that from what you're saying from your evidence, is whether there was enough in terms of supply, and then whether the supply that was available was adequate. I can correct me if I'm wrong, but I think what you're saying, you didn't, when I asked if members had said, had they run out, you didn't come back to me and say, yes, they did. So am I correct in assuming that GPs weren't running out of PPE, but there were anxieties about the suitability of the PPE?
I think there will be. I'll just finish and hand over to my colleague, but I think there were many instances where people didn't have a full set of PPE that they felt met the risk assessments that they were making, or that we could see that there were some environments where a higher level of PPE was required in some of the hospital secondary care settings, and I think general practice in particular, but I would extend this to other contractors in primary care, so dentists, optometrists, pharmacy. I would say that these groups felt as if either the guidance that we were given round about what PPE was suitable was tailored to what was available, or that I don't think there was confidence from the profession that they had the right armour on, that they had the right tools for the job.
And I'll maybe put this question to you, Dr. Lunan. If a GP didn't have the right tools for the job, the right PPE, if it was a more basic mask than was required, what could a GP do about that? If anything, perhaps the answer is nothing, but...
No, well, I think that it's a good question. There was variation in the guidance that I guess GPs were reading, depending on whether it was maybe WHO guidance or national guidance around what level of protection was necessary working in a general practice setting. So the PPE that we were distributed at the beginning was to protect us against droplet spread, which is how we understood that COVID was transmitted at the very beginning. So that was the fluid-resistant surgical masks, the ones that you can buy in a chemist, a pair of gloves, a thin apron but no sleeves, and goggle or visors. And as time went on, I think there was a lot of concern within members that is this the right level of PPE for the work that we are doing, particularly if you're examining people who are coughing on you. Is that adequate protection if we're seeing people who don't want to wear a mask and are coming into your consulting room? Does that mean that we have to change who those people are able to see? Maybe see doctors that are themselves at lower risk of contracting COVID. So there was concerns about the quality, there was concerns about the quantity, and there was concerns about the reliability of supply, and there were lots of workarounds that came about because of that. So Dr. Williams mentioned that often the community would kind of rise to the challenge and drop in things like scrubs. They would often drop in things like homemade masks as well, which we would often wear and sometimes hand out to patients in the practice as well if people didn't have masks themselves. But many GPs actually chose to purchase their own. They chose to purchase their own FFP3 masks online, like many members of the public did, because they didn't feel adequately reassured that the fluid-resistant surgical masks were going to give them adequate cover.
And were they able to, I take it there were sufficient supplies in the marketplace for GPs to obtain those FFP3 masks?
They were subject to the same supply issues as everyone else because they were going through public routes, so I guess there would not have always been a reliable supply of FFP3 masks. It would just depend on what they were able to order, but they weren't available through NHS pathways because our PPE was this other level, this other standard.
So excuse my ignorance, so a member of the public might go on to, I suppose better not mention any names, but onto the internet and use, find the product on the internet. Is that what GPs were doing, or could GPs go through some specialised kind of procurement consortium type? No,
I think people just bought it online in the same way that the public would. There wasn't a special access pathway for GPs who wanted to buy a higher level of PPE that was considered, acceptable as deemed by our local infection control guidelines. I mean, I think a lot of people were content with the level of PPE, but some people were really concerned, and the evidence was sometimes a bit conflicting at the start around how well protected you would be wearing the fluid-resistant surgical masks. They really only protect the person that is being seen by the person with the mask on. They don't protect the person wearing the mask. It's about protecting other people. So for that situation to work, you need both the doctor to be wearing a mask and the person that you're consulting with to be wearing a mask as well. And of course, that didn't always happen.
Okay. Moving on to a different topic, from paragraph 39 on, you talk about pharmacies and prescriptions in the statement. And I wonder if I could just ask you some questions. It's not dealt with in the statement, but was there a trend towards people going to see pharmacists where they had previously would have gone to see a GP? And I'll put that to Dr. Lunan. Was that a general trend that you're aware of?
It's difficult to know for sure. I know that pharmacy was really busy. Our community pharmacy colleagues were amazing during the pandemic because they're also frontline, open door, and they were seeing lots of people who were concerned about their health. They had a lot of footfall into practices for people collecting prescriptions. We tried to help minimise that by taking batches of paper prescriptions over to them, so that they wouldn't have multiple people coming in with one. They would have maybe one person from a practice coming in with 20 or 100, depending on how many we'd signed. We don't have end-to-end paperless prescribing in Scotland, so we still rely on signed bits of paper that need to go from building A to building B and be collected by person C. So it's quite contact intensive. I don't have the figures to hand about whether there were people seeing pharmacists who would ordinarily have seen GPs. If that was the case, some of that may have been appropriate because there is a kind of long-standing background campaign to try and encourage people to see wider members of the primary care team, which basically are any clinician working out in the community who has different sets of skills and expertise depending on what the problem is. So we know that community pharmacists are extremely skilled, for example, in dealing with minor illness and dealing with minor skin conditions and giving advice about lots of different healthcare issues. And it may have been that people were starting to make more use of that than they had before the pandemic. So seeing community pharmacists wasn't necessarily an inappropriate thing, but it may have driven that change quicker than it ordinarily would have happened. I think that one of the, again, silver linings, if you can use that word, from the pandemic was that our relationships with our community pharmacy colleagues were really strengthened during the pandemic, because we had to work really closely with them to make sure that they were safe, that we were minimising footfall into their buildings, that we were thinking of all the ways that we could to make sure that pathways were streamlined, safe for patients, safe for staff.
Can I pick you, Dr. Lunan, could I maybe pick you up on just a couple of points that you dealt with there? I suppose the first point, the quicker point, is that and simply speaking from my experience, is that the local pharmacy, there was a queue to go into the local pharmacy, certainly at the beginning of the pandemic. Now, I wonder, would that exclude then certain people visiting the pharmacy, people that may be shielding, or people with mobility problems? Would that perhaps exclude certain people using pharmacies?
I mean, I think that the queues were very apparent, and the queues were more pronounced in more socioeconomically deprived areas, because that is the trend across the use of healthcare across the system. And the queues were partly because of increased workload, I'm sure, but also because people were having to socially distance, so that the queues were longer than they would have been. I think that people would have made decisions not to visit pharmacies because they were scared of standing in a queue, contracting COVID potentially, maybe being out in bad weather. So people who had a disability or mobility issues or were shielding with more complex health problems, I would imagine would have experienced that as pretty frightening, in the same way that they experienced accessing many different healthcare settings as really frightening. And it's probably one of the things that delayed people coming forward with health issues during the pandemic that we were acutely aware of and worried about. I'm sure that the pharmacists would have done some work with the people that they knew well to try and triage people in their queues and at the front door, to make sure that the people who seemed the most unwell or the most unable to stand in a queue could be seen more quickly. I don't know what the details would be around that, because it would be more appropriate to ask them, but I'm pretty sure that would have happened.
Okay, thank you. And maybe the follow-on question I'll maybe put to Dr. Williams, because it is something I'm sure you're both qualified to answer. Thankfully, I'm not particularly familiar with prescriptions, but if I understand Dr. Lunan's evidence, is that a prescription is still a signed bit of paper, essentially?
In Scotland, we have the infrastructure for a message to be sent from the GP practice to the community pharmacy, so that it can be seen what item has been prescribed. But legally, for that prescription to be dispensed, there needs to be a bit of paper with a signature on, and for the community pharmacy to get reimbursement for their work in prescribing, in dispensing, supplying that medication.
I'm sure we could spend the whole afternoon in this topic, but I mean, in many walks of life, electronic signatures have now become the norm following the pandemic. Is there any reason why, and I appreciate I don't want to open a can of worms, but is there any reason why those prescriptions couldn't be signed electronically, or that they have to be still a hard bit of paper with a wet signature?
So there's two elements, and there is an ongoing programme of work that's the digital prescribing and dispensing pathway, or DP. But essentially, you need the digital infrastructure in place, and you also need a change to legislation.
I won't. This probably perhaps goes out with the scope. In terms of, I wonder if I can move forward to, it's paragraph 57 of your statement, and principally 58 as well. And you talk about the changes to clinical work, which, and you tell us that routine screening was paused. When you say routine screening, what type of screening?
So I suppose we should clarify the definition of screening. So screening is an evidence-based process where you test a certain section of the population, knowing that you are going to do more good than harm in terms of the results that are returned. So there are some specific conditions that you can look for in sections of the population that you can then treat. You can detect at an earlier stage, and there can be more treatment options available at the point of detection. So the bowel screening, for example, people will be sent out a kit to their home that they can test themselves once they're over the age of 50. That process kicks in. There's a national breast cancer screening, and I suppose the screening that general practice has been most involved with is the cervical screening, and I might defer to my colleague Carey Lunan to, if that's okay, Carey.
Of course. Yeah. Dr. Lunan?
Yes, no, absolutely. So fairly early on, we were advised that routine screening would pause. As Dr. Williams was saying, that includes the breast, bowel and cervical cancer screening programmes, also screening for abdominal aneurysms and for diabetic eye disease. a couple of months into the pandemic, there was a keenness to try and reintroduce screening, because I think we were all acutely aware that it would be generating a backlog and potentially delaying diagnosis of early cancers or pre-cancer conditions for the cancer programmes anyway, which is what they are designed to pick up. Also, some people are on non-routine screening, which means that they have a more regular invitation to come in and get tests done than someone who's on a routine screening programme where their tests have been normal previously. So I think it was May, June time in 2020 that there were plans to reopen screening programmes within general practice, which is the cervical screening programme, the smear test, which is done by practice nurses in the vast majority of cases, and an agreement that we would focus to start with on the people who were at higher risk. So people who had previously had an abnormal smear would be invited in first for their follow-up smear, and once we'd caught up with the backlog of people who were waiting for their follow-up from a previously abnormal result, we would resume the normal routine screening for people who were on the normal recall pathway, which was a smear every 3 years.
How long did that backlog take to catch up?
It probably took a good few months. Certainly over the first couple of months, I think non-routine screening, so the higher risk group was due to start, I think, at the end of June from memory. I'd need to double check the dates now. But it was recognised that those smear tests were going to take longer than normal because they needed to be done in person, wearing PPE, cleaning between appointments, all the things that we've talked about already. They weren't the usual 15-minute appointments back to back. We had to accommodate a probably 50% reduction in the amount of cases that we could get through in a normal working day. But our practice nurses worked incredibly hard to get through that backlog, and then I think we were able to resume normal routine screening, I think certainly by the end of 2020. There were discussions that we were involved in when we were talking about resuming screening, about whether or not that workload could be shared out beyond just general practice, because of course smear tests don't need to be done in general practice. That's just where they've traditionally been done. And we had wondered about whether we could have a whole system approach where we've got colleagues trained in smear taking across the wider system within hospital settings or clinic settings that could maybe help with the backlog. I think at the end of the day it was felt that general practice was where the screening should be done, and that's where it was done. And from memory we managed to get through the kind of non-routine backlog within 2 to 3 months, which is pretty phenomenal, and then managed to get back to more routine screening by the end of the year.
This might not be a question that you can answer, but in terms of screening and tests that would have been done by the GP practice, if that was delayed, and we've heard that there was a delay, would that have led to progression of diseases which would create more of a pressure on the secondary care, the hospitals, in the future? I'm just wondering if that contributes to the backlog that we hear in the press every day.
Yes, I mean, I think we can't know that for sure, but we have to assume that that is the case, because there's a reason that, for example, cervical screening at that time was every 3 years, because the evidence tells us that that is the most effective way to do it. Doing it every 3 years means that you pick up enough to make it a cost-effective programme. So if you're going to delay doing smears, then you are going to pick up pre-cancers or early cancers at a later stage. And that was why there was a keenness to try and get the routine screening up and running as quickly as possible, with a focus on the people who were highest risk getting screened first. So I don't know the exact figures in terms of people who were picked up with a new cancer diagnosis or a pre-cancer diagnosis when things opened up again across the whole of the screening pathway. And of course we were only doing cervical screening in general practice. There's also the breast and bowel screening pathways which had to open up outside general practice. But I think we have to assume that there will be some of those new diagnoses that may have been caught earlier if screening hadn't been paused.
Thank you. Dr. Williams, is a very general question. I'm going to jumping completely onto a different topic, but in terms of the impacts felt by GP practices, was there, or are you aware of any difference between impacts felt within different geographical locations, and I have in mind maybe a city GP practice that's in a perhaps in a poorer area, an urban practice that's perhaps in a relatively affluent area, a rural practice, perhaps an island practice where there was very restrictions. Are you aware of any kind of differences in terms of the impacts felt by the surgeries depending on where they're located?
Yes, so I can certainly speak to the impact in rural, remote and island areas. General practice in those settings, the GPs, the practice is very much a part of the community. So even simple things like removing the waiting room as an area where people might meet and speak is disruptive to the local population. I think the populations are sympathetic to the clinicians that are living and working there, but as we described at the start, there was such profound changes to some of the ways that things were done, and again I come back to the emergency medical responder side of things. There were changes in terms of what whether people were allowed to go and do CPR without full protective bodysuits and masks, and these were things that we didn't have generally. So I think some of the ethical dilemmas that were there, services that we'd previously provided. I think you've picked up on the difficulties round about home visiting and the things that we wanted to do as general practice, but that our risk assessment told us that this might take this might expose us to disease that might then go around the team, and some very difficult decision making round about how do you keep a service going, how do you ensure that the service keeps going, and these are often, let's say, small teams where you don't have, in terms of resilience, where you don't have lots of layers. If one person goes missing from that team, or has to self-isolate, or has to work remotely because because they've got symptoms, and you assume that to be COVID, or someone develops long-term problems following an infection. That in remote and rural areas, I think it's very pronounced, and that and it's felt. That not only within the team, but I say across the community, there's a there's a strong bond in these areas.
I take it you work in a rural practice, do you, Dr. Williams?
I work in a rural practice in Highland currently, and I've worked in many other rural practices earlier on in my career. So yeah, I've seen say some of the differences between some of the urban practices.
Dr. Lunan, again, sorry, could you wish to follow up on that?
Just on the same question, if that's okay.
Of course.
Dr. Williams and I work in quite different practices, which is probably quite useful for being able to reflect on that. So I worked during the pandemic in an urban deprived area practice, and I think that we're all very aware of the impact that COVID-19 had on highlighting the existing health inequalities that we have in Scotland, and the fact that it also worsened them. So I think what we noticed was during the pandemic there was almost a triple whammy of COVID. Our patients were more likely to get COVID because they were more likely to be working in frontline jobs that didn't have the choice of being able to work from home. They were often, frontline jobs where the prevalence was high, so they were more at risk and more exposed, poorer underlying health to start with, more likely to die from COVID. If they caught COVID, 2 to 4 times more likely to die, higher levels of ethnic minority populations in more deprived areas, which also gave an additional risk. And then when vaccine was rolled out, the vaccination rates had lower uptake in more deprived areas, which is a historical finding. It's been seen with every vaccination programme that we've ever had for lots of complex reasons. So I think that we were acutely aware that health inequalities, COVID was following the same social gradients that we see with many other diseases, but it felt particularly stark during the pandemic. And it was worsened by things like having to consult remotely when people were digitally excluded. So if people didn't have access to data on their phone or reliable broadband or a private space in their home, or they had cognitive impairment or English as a second language, or if they struggled to describe the things that they were worried about. These were all things that made remote consulting much more difficult in a more deprived area. And I think brought in the issues that we talked around clinical judgment and just bringing someone in to see them face to face and get that sense check. We also saw a rise in things like drug-related deaths, in mental health problems, in safeguarding issues around vulnerable families and domestic violence rates. All of those things rose during the pandemic. In the more kind of affluent urban areas, the main challenges would be that the main risk factor for COVID was age. And if you live in a more affluent area, you're more likely to live into old age. So we know from speaking to colleagues across the country working in the suburbs with older, frailer populations that, again, that was incredibly difficult, different challenges, having to have very complicated and often very sensitive discussions with people about their existing health, what they would want to happen if they became sick with COVID, would they want cared for at home, would they want admitted to hospital, what was realistic to expect if they did get COVID, what social supports did they have, lots of issues around social isolation for older people. So there were lots of challenges that were core to all of us as GPs working across Scotland, and then there were some particularly unique challenges depending on the demographic of the population that we were looking after.
Thank you. You said a lot of things there that I wonder if I could pick up on a few of them. I'll list them and then I'll go through them one by one. You talked about substance abuse, you talked about safeguarding, you talked about mental health, and you talked about digital exclusion. I suppose just doing them in reverse order. Digital exclusion. When we talk about digital exclusion, we talk about people that obviously may not have either the equipment or the capacity to use the equipment to consult remotely. Is that focused on particular groups? I mean, does that tend to be people that are elderly, that are frail? Was there particular people that might have been more digitally excluded than others?
I guess the people that we knew were more likely to be digitally excluded were people who were older and less confident in using technology, people who had sensory impairments, so had difficulty with vision or hearing, people who couldn't necessarily afford the equipment or the data or the reliable broadband to be able to access things like Near Me. But we also know that there were other groups, so people with learning disability, people with cognitive impairment, so folk who'd had previously had a stroke, for example, or who had other neurological conditions, people who had English as a second language were also more likely to experience difficulty around digital consultations. But other things, for example, just being able to access a private space within your house to have a sensitive conversation about something that's worrying you is more difficult if you're living in an overcrowded home, and particularly if there are issues around domestic security at home, that felt particularly worrying. So there were lots and lots of things that we needed to be actively considering when we were speaking to people on the phone or with Near Me to make sure that this was an appropriate and a safe way to be assessing someone and consulting with someone. And the RCGP was involved in writing guidance for GPs to just help to sort of sense check with people. Does this feel okay for you? Are you able to speak just now? Have you got somewhere private to go? Do you know how to use the technology? What would your preference be? And we would try and accommodate that as far as possible, given what was going on around prevalence in the local area at the time. But I think digital exclusion was a big concern during the pandemic and remains one, because we need to make sure that as we recover the NHS and we develop more hybrid ways of working and more telephone appointments or video consultations, that they don't worsen health inequalities, because there are many consultations that are more complicated, that need that face-to-face element, not just to assess somebody but also to build trust and connection and relationships with people, which is a big part of what we do as GPs.
Okay. Thank you. One of the other points you mentioned was mental health, and we see at paragraph 66 of your statement that there was an Audit Scotland report referred to which said that accessing mental health issues became worse as a result of the pandemic, and I suppose, again, we could talk about this all afternoon, but relatively briefly, could you explain to us, if you can, what mental health services weren't available as a consequence of the pandemic, and what people could do to obtain mental health services, if anything, during the period March to December 2020, when you were the chair of the Royal College?
So we know that a lot of the third sector organisations were struggling to be able to see people face to face. So third sector voluntary charity organisations that a lot of people got mental health support from either were not financially viable during the pandemic, or weren't able to staff the service, or weren't able to stay in the premises. So a lot of those services became unavailable. In terms of specialist mental health services, a lot of those went online, so became remote by default, and a lot of patients with mental health issues often struggled with that. Not all of them. Some people like a telephone appointment or a video consultation, but access to mental health services felt more difficult. In general practice, it's a big part of our normal workload. So we see lots and lots of mental health in normal times. Probably about a third of our consultations have got a mental health component to them. But during the pandemic, it's estimated that rose to probably about half of our consultations would have some mental health element to them, whether it was low mood or anxiety or insomnia or other issues, or more significant mental health issues. So
can I ask, those issues, were they caused by effects from the pandemic, whether it be lockdown restrictions, or Dr. Williams looks as if he might be willing to offer an answer to that.
So aside from the health and social care and third sector support, people's lives and routines were disrupted. People experienced financial pressures that they had never experienced before, or uncertainties about their future work, or about their relations, or about their relatives who lived in another place, or whether they could visit their elderly parents, or what would happen if somebody got ill. Some of the things that in ordinary times might cause you stress or upset or worry might all come at the same time, or might be magnified. And so, say people who had mental health issues that were coping on a day-to-day basis before, I think were very much then feeling pronounced effects. Or I think there were lots of people who, where their functioning what became worse, or where how they felt became worse. I think when it also appears more difficult to access help that they would have previously felt able to access, if there are, so even if there aren't actual barriers, if they're perceived barriers, or if they aren't confident in speaking to, in saying to a receptionist, I have depression, it's got worse. If people can't navigate these few simple steps into to speaking to a GP, or to another clinician in general practice, which would ordinarily be most people's sort of first steps towards help and assistance, then you're looking at problems out there.
And I suppose this takes me on to the substance, and I'll come back to the safeguarding point. But in terms of substance, I maybe just put this to Dr. Williams, because as a practicing GP, I think you can speak to this. You don't need to be the chair of the Royal College. But was there an increase in alcohol and drug use that you're aware of during the pandemic?
Yeah, there was a change in pattern, and a change in where people would consume alcohol in terms of drinking at home, rather than going to pubs and bars, especially where people aren't able to congregate, and they've got a real change in how people are ordering food and drink and having deliveries. But yeah, there's a range of organisations that could document the changes in pattern and the harm that's occurred.
That's the question. A change in pattern in itself isn't necessarily a bad thing, but when use goes to abuse, that presumably is a bad thing. Did you see use go from use to abuse? if that's the term.
So I suppose the fear is that the things that you're not seeing, or the people that aren't consulting, but at the same time you know that sales are going in a direction that are bound to be causing harm, or by the time that you see people, they've already experienced harm.
Dr. Lunan, just to pick up the last of the 4 points that I think you identified, it was safeguarding, and I don't want to spend too much time in this. We have limited time this afternoon, but you deal with safeguarding in your statement at paragraph 73 and identify that GPs play an important role in safeguarding and deal with family and child and social workers and so forth. My question's in fairly sharp focus. In your opinion, do you know if the absence of that during the pandemic, is it likely to have led to preventable harm to children and domestic violence?
Or the absence of the usual organisations that wrap around, like education, social work, health visiting, general practice? Is that the question?
Yes, essentially the role that the GPs play, if that's taken out of the equation, does that increase the risk that there's harm to children or domestic violence?
I think that there's, the collective responsibility of all the organisations that are placed to support vulnerable families, whether it's schools, whether it's social work, whether it's health visiting, whether it's midwives, whether it's general practice, if all of those organisations are less available for whatever reason because they're having to operate in a different way during the pandemic, then yes, that will have increased harm to families that we were not seeing or hearing from because they were missing in the system. Under very stressful circumstances, we know that the rates of domestic abuse went up, for example, and we know that children's mental health deteriorated during the pandemic, and that it was pretty stark when schools reopened that teachers were reporting concerns about the fact that their vulnerable children had deteriorated in the time that they hadn't seen them.
Thank you. Dr. Williams, I wonder if I could put this question to you, and I'm moving on to shielding now. And you deal with shielding under paragraph 81 of your statement, and maybe just for brevity I can read out myself that the regulations that GPs worked under were not straightforward. The Royal College felt excuse me, that there was not good correlation between the list of conditions that had been drawn up and those who were vulnerable of becoming very ill. We objected to the terminology of extremely clinically vulnerable. Did the lack of clarity in the guidance cause GPs difficulties? And if so, what were those difficulties?
So I should explain to help inform things that the clinical record that GPs keep can be a lifetime clinical record. It can be very detailed. It is carefully coded. It is curated. And even when patients move around between practices, we can still have a very granular idea of procedures that people have gone through, or illnesses that they have had, diagnoses that they've had. And in terms of the process around about shielding, I think that started with what model you've got. Do we know who's going to be affected who's going to be at most risk of COVID and most at risk of complications and serious outcomes? And of course, we didn't know that at the start. So you have a model which you then need to deploy very rapidly, and then you need to check whether the right people were on the list. So along the way, there was various groups that were found that were known about in hospital systems, but weren't particularly apparent from looking at the codes on GP systems. And I think my colleague Dr. Lunan might be able to add some more useful information about shielding. I think she dealt with the start of it.
Thanks. Yes, I mean, I think that at the beginning, the list that was drawn up of the people who were being recommended to shield were largely people who fell into what we call single disease categories. But actually, as we began to see the data coming out of who was dying from COVID, it just wasn't as straightforward as that. and it seemed to be that people with particular combinations of different diseases would be more at risk. So, for example, if you had obesity and you also had diabetes and you also happened to be from a certain ethnic minority background and your age was higher, you were very high risk, and that wouldn't necessarily have been picked up in the initial shielding categories that were announced. So I think it created confusion in two ways. One was that there wasn't always a common understanding between specialist services looking after people with one illness, one disease, one condition, and generalist services, i.e. GPs, who are looking after people with lots of different conditions with other stuff thrown in that makes it more complicated. For example, ethnicity, for example, poverty, or health-harming behaviours like smoking or obesity, or things that make it more complicated than that. So people would often be receiving two different shielding conversations, one from the hospital and one from their GP, which created confusion for patients sometimes. But we did have the opportunity to add people onto the shielding list if we felt in our clinical judgment that they were more vulnerable and that they would benefit from the extra protections that shielding would bring. And that often just required a discussion with the patient to see how they would feel about that based on their own risk.
Can I ask a follow-up question? You explained in your evidence there that you began to see that people that were passing away from COVID, it wasn't simply people that were on the shielding list, there was a range of factors. Now, we're looking at this with the benefit of hindsight, but what I'm interested in, as those other factors developed and people say, oh, you know, this is a critical issue, was the shielding guidance changing to reflect that, or was it not changing sufficiently quickly to reflect that? I think Dr. Williams looks as if he's... Sorry. But I'll let Dr. Williams, and then perhaps I'll pass it briefly over to you, Dr. Lunan, if I may.
I mean, I think the Scottish Government team that were working on that might be better able to inform you with numbers. But I think that eventually they recognised that by being told to shield and by people being told that they were on a list, it then started off, I guess, a mindset or behaviours or what people thought how much people thought they needed to limit their interaction with wider society, and of course a lot of the background circumstances changed. So I think over time it became apparent that the way that the group that had been told that they were extremely clinically vulnerable, actually that some of the behaviours that was then wasn't influencing in the right way, and as Dr. Lunan has said, actually there were other groups with combinations that were far more at risk, and that was being borne out by the death certification process.
But I suppose I appreciate you said you should put the question perhaps to those that drafted it, but as somebody at the front line, I just wondered if you had a view whether or not the shielding guidance was being amended sufficiently swiftly to capture what was these new factors that were important.
So I don't think there was the technology in place to be able. So there was the ability to put a marker on a large group of into people's clinical notes, but this was something that hadn't been done before. So it hadn't been realised that you couldn't then easily take that off.
So to jump in there, and I apologise in jumping in, but just for the lessons to be learned, is that a lesson to be learned then in a pandemic there should be a facility for GPs to be able to do that?
So I think if you're going to give an instruction to a subset of the population to be doing something specific, and that is to be especially distanced from normal parts of society, then you need to understand the implications over time, so how that person will adapt psychologically. And so if you aren't putting the right people onto that list and giving them the relevant support, then you're going to encounter problems. So I think that I think measures were taken with good intention, but I don't think that the system responded quickly and well enough to problems that were stacking up and that must have been visible to parts of the system.
Thank you. Dr. Lunan, was there anything that you wanted to add in addition to what Dr. Williams has said?
Just a couple of quick points. One, I would echo what Dr. Williams has said, is that shielding was a really big deal. To tell someone that they were shielding was quite a frightening thing for a lot of people and required them to significantly change and limit their life. So there's a huge risk-benefit decision needs to be made about whether or not someone needs to be in the shielding group. And I think as time went on, we realised that some of the conditions that were felt to be at high risk of COVID probably weren't as high risk as we'd originally thought. But it's far harder to remove someone or remove a group of people from the shielding list than it is to add them in the first place, because people are anxious then about coming out of it. So I think that was one of the challenges. I think there was recognition of the fact that we needed to not think in single disease pathways, and we needed to think across something called multiple morbidity. So if you've got 2 or more long-term conditions running together, you were more likely to get sick with COVID if you caught it. And I think that probably 2 or 3 months in, we began to have much more awareness of the impact of ethnicity, and that began to get a lot more traction in terms of how we would risk assess people. I think the impact of poverty took longer, and I think that what we need to recognise is that age isn't a straightforward binary thing. Someone who is 65 living in poverty is nearer the age of an 85-year-old person living in a much more affluent situation. So there's something about weighting age according to deprivation, so that we think about biological age and not chronological age when it comes to shielding. And exactly the same could be said about rolling out vaccines, because many people living in poorer circumstances never reach old age. So there's something about adjusting age thresholds, although I appreciate that's not straightforward to do. I think that is learning for next time.
Thank you. I don't have...
Mr. Dunlop, you've actually used your allotted time for these witnesses. If you need more time, we'll have to have a break for the stenographer's purposes.
I will be about another 5-10 minutes. I promise to be finished before 2:55. However, I think a break, I'm sure, I don't think there's a witness on after. So
no, there isn't. No, there isn't.
I'm entirely in your Lordship's hand. I apologise, I've just got a few more questions.
If you're only going to be 5 or 10 minutes, I'm sure we could run that through without interrupting.
I only have 2 topics I just want to deal with, and thankfully Dr. Lunan's helpfully basically identified the health inequalities. So Dr. Lunan, you were mentioning there that obviously the people that live in social deprivation, a younger person, will be the same as an older person in a more affluent area. Now, in terms of you deal with health inequalities, were there particular groups of people that were affected by COVID more? And I don't need to go into detail. If you could list the groups, rather, I don't think we need to go into a huge narrative unless you think it would be particular benefit.
People working in frontline jobs who weren't able to work from home, people who had poorer underlying health, and we know that people living in more socioeconomically deprived situations develop diseases that older people would develop 10 to 15 years earlier. People who were less likely to be vaccinated, they were the people that were more likely to get sick and to die from COVID. That's in a very brief snapshot of who was more likely to, but obviously I could talk about this in much more detail.
Thank you. No, I'm sure we could. And what I would say is we have your statement, and your statement is evidence. Just finally, Dr. Williams, if we can just take you to paragraph 172 of the statement. You identify that there's been an increase in private healthcare since the pandemic, which is attributable to kind of long waiting lists and backlogs. Does the increase in people taking out or going privately, does that remove the pressure from the NHS? Does that enable them to essentially, and why does it not?
So, private healthcare is, by and large, providing a more limited set of investigations and procedures, often making use of staff, be they surgeons, be they nurses, who also have NHS jobs. So I can understand when people are faced with a long waiting list, or potentially very long waiting list, if they're seeking a diagnosis and here's a test that they could get done without needing that wait. I can understand the decision. My hope would be for an NHS that wouldn't have these waits involved, that wouldn't have the delays that people face. But I wouldn't want others to think that private healthcare is the solution to the problems that we currently face. I think there's certainly people look for quick fixes often, and in some ways, if you get a hip replacement that revolutionises what mobility you have, then that is a fantastic change in circumstance that you wouldn't want somebody waiting a couple of years delay. But it's difficult for me to speak more widely about. I think the increase in private healthcare is a consequence of the system pressures, and those who are affluent or have access to insurance, or who are making the choices that something is necessary, are often making sacrifices that I don't think they should need to make.
Am I correct? Just don't wish to lead you in your last question, but am I correct that what you're saying then essentially is that a part of it is that it's the same medical practitioners who are providing that care? So if we were to go into another pandemic, there wouldn't be an answer by looking simply to the private sector to essentially fill the gap that wasn't being provided by the NHS in 2020.
So I think you need to go one step backwards and look at why some of these waiting lists got longer. So, for example, for large joint replacements, for hip replacements, knee replacements, if surgical space was being repurposed or wasn't able to be used, if these operations weren't able to go ahead, if if the need for intensive care support round about an operation meant that it became a completely different risk, then I say there are multiple reasons why any pandemic, I think, would increase certain waiting lists. But there and the change in how people have accessed the healthcare, in some respects, the sacrifices that people have made when there's been periods of limited healthcare resource, the decision making round about that is difficult for doctors and patients alike. I think having a health system that has capacity, that has reserve, that has resilience is important.
Thank you. Before I thank you both for your time, Dr. Lunan, was there something, I saw you had your pen up, but maybe it was just, I hold my pen as well. I don't know if there was something you wanted to add, but...
No, it's just that the private healthcare, well, can I briefly, 30 seconds about private healthcare? I think that there are lots of people who can and can't afford to pay for private healthcare that are choosing private healthcare because they feel they have no option. But as Dr. Williams says, it's often the same workforce, and often the work will come back to the NHS for follow-up, where tests are done in private healthcare systems that wouldn't necessarily have been done in the NHS because they wouldn't have met the thresholds for needing tests to be done. But I think more importantly than that, in the long term, if you have these two-tier systems of healthcare, it removes the collective incentive of the whole of society to argue for or vote for a public healthcare system that works well for everyone, because some people are getting their needs met elsewhere, and so ultimately that undermines the social function of the NHS.
Okay, thank you. Is there anything else that you would like to add that you think would assist the inquiry in its deliberations before I thank you for your time? No.
I think I would just like to say thank you for the opportunity to give evidence today that I think general practice as a profession was remarkably adaptable and flexible. I was really proud to be a GP during the pandemic, during really difficult times, and in many ways it brought us closer to our patients. I think recovery has been really difficult. A lot of the media coverage around general practice has been really difficult in terms of the impact on morale, and we're still working to try and address that. But I think that the way that we were able to support not just the medically vulnerable but the socially vulnerable feels really important, and I felt really proud to work during the pandemic as a GP in the NHS.
And may I extend my thanks to both of you and the Royal College for giving your time freely and going to such an extent of preparing such a comprehensive statement. We can't essentially do the inquiry without parties like yourself, so I'd extend my thanks to you. I have no further questions. I don't know whether my Lord has anything that he wishes to add, but...
No, just my thanks to both the doctors. I'm very grateful. And that concludes proceedings for today. Thank you all.
Thank you, my Lord.